Welcome to the AO Spine Research Top 10 podcast with Myelopathy Matters from Myelopathy.org.
In this episode, we'll be hearing about the number 6 priority, perioperative rehabilitation.
And we're going to be hearing from neurologists Dr. Armin Curt, as well as Julio Furlan, and Tim Boerger, a person living with cervical myelopathy.
My name is Dr. Ben Davies, neurosurgeon, scientist and founder of Myelopathy.org.
And I'm Dr. Michelle Starkey, a scientist and director of Myelopathy.org.
This is AO Spine Research Top 10 with Myelopathy Matters.
Welcome to this special podcast series with Myelopathy Matters, covering the top 10 research priorities that have emerged from the AO Spine Recode DCM research prioritization setting process. Ben, perhaps you could give us a brief reminder of what the AO Spine Recode DCM project is.
Certainly. So this was a process that brought together people living with and working with DCM to try and establish some guidance that could help individual researchers work faster, I guess, to find outcomes that could change clinical practice. And one of the areas of guidance was, what should we be researching? And this process really involved asking people working and living with the disease, what were the uncertainties that they faced on a day-to-day basis? And we turned those into research questions, which were then prioritized, and we emerged with the top 10, which represents the perspectives of the entire field and what really we need to be investing time, resources, and money into answering.
But of course, the research community needs to understand what these priorities are and why they matter. And that is exactly what we're exploring in this special podcast series. Today, we're going to be considering priority number 6, perioperative rehabilitation, or as the full research question states, what is the role of rehabilitation following surgery for DCM? Can structured post-operative rehabilitation improve outcome following surgery for DCM? And what are the most effective strategies? And to provide some clinical context and background to this question, I started by asking Tim Boerger, a person who's living with DCM and who's undergone surgery for it, but who is also a clinical research student, what his experience of perioperative rehabilitation has been.
I had surgery for DCM and also radiculopathy about 6 or so weeks after I got diagnosed. So my process from diagnosis to surgery was fairly quick. And I tried some preoperative rehabilitation, which didn't go too far in alleviating any of the symptoms of myelopathy that I had. But then after surgery, I didn't have a whole lot of formal rehabilitation for a variety of personal reasons, time commitments, etc. But also part of that was I was fortunate that the symptoms of myelopathy largely resolved fairly quickly after surgery. And I'm believing a substantial part of that was probably related to how quickly I got surgery after I got diagnosed, right? So, for example, before surgery, I had foot drop walking down like the hallway, but that didn't develop until about 2 weeks before I had surgery. And I had surgery and then the foot drop was immediately gone.
So in your case, was the rehabilitation to prepare you for surgery, or was it because at the beginning they thought they might be able to avoid it?
Particularly, I wanted to do rehabilitation beforehand to see if I could postpone surgery until a slightly more convenient time. I'm a PhD student, and I was hoping that I wouldn't have to drop all of my classes. That didn't work out, and so then I ended up having to medically withdraw from all of my courses and retake those courses to satisfy the requirements of a PhD. I wanted to do some conservative therapy, in part to see if we could push off when that surgery was going to happen. In my particular case, it didn't do a whole lot. And there was a real limitation on what therapies could be done because of the neck pain, arm pain, etc. So all the therapy was really designed around trying to alleviate symptoms And it would alleviate symptoms for a day or two, but then they'd come right back. And there was no real progress. So we went to the surgical route, and obviously the radiculopathy symptoms resolved largely, but also some of the myelopathic symptoms resolved as well.
And has that remained the case? Are you doing quite well now?
I've since developed what are called hypertrophied uncovertebral joints, but there's really not a whole lot they can do until it's bad enough that they need to do surgery. So I'm in a bit of a holding pattern. It's rough in that it can really impact trying to be physically active and trying to exercise. I fairly quickly figured out that running makes it worse. The up and down, the accelerations of running makes it worse. I ran collegiate track for 2 years, not very well, but I did it. I ran 10Ks. I actually ran a half marathon 3 months before I had developed symptoms of myelopathy. And I don't think I could run for more than a mile or two at this point, just because it's just too brutal.
So when this priority is resolved, how do you think it will benefit people with DCM as well as their carers and the healthcare professionals?
This is really a question that it has to fit together with some of the other research questions. For example, we need to have a pretty good idea of what the natural history is. And we need to have a pretty good idea of when to do surgery, who to do surgery upon, etc. Perioperative rehabilitation, so either rehabilitation before surgery, rehabilitation shortly after surgery in a skilled nursing facility, rehabilitation 6 months out, could really help to improve the environment of recoverability. Because we know in a variety of, say, orthopedic conditions like ACL injury, it can be very beneficial to have a structured rehabilitation program prior to surgery to get the individual to the most optimal point where recovery following surgery is most optimal. Likewise, following surgery, it can help to increase the recovery of strength and walking and coordination and dexterity in your hands, etc. So I think once we identify what kind of exercise prescription, frequency, the intensity of exercise, when to start it, how long to do it, etc., as well as other kinds of rehabilitation-based therapies, might really help to enhance the improvements that people can see from surgery alone, especially because so much of the impact is on walking function for people with cervical myelopathy. And you can extend that also to potentially like a high-intensity exercise for hand recovery, etc.
And obviously, different healthcare systems around the world do things differently as well. So that's another factor that's coming into play here, I think.
As a global spine community, we really need to take a look at the differences in healthcare system that could also be a key contributor to how well a person is able to recover. And this kind of gets at what's called social determinants of health. Your socioeconomic status, what kind of educational background you have, all of those other factors could be potentially really important in establishing what are going to be good rehabilitation protocols. So I think if we can improve quality of life and functionality of people with cervical myelopathy, that's going to extend to improving quality of life of the caregivers as well. And that takes a large burden off of them and takes a large burden by extension off of society as well. Maybe the caregivers don't have to drop down their employment status because they have to spend more time taking care of their loved one with cervical myelopathy. And you just get this, in a way, a trickle-down effect of now it's improving society as a whole.
And so what about healthcare professionals? How do you think this priority being resolved would help them or would impact them?
For healthcare professionals, I would say the most substantial benefit would be in really clarifying what kinds of recommendations do they give. Let's take the example of a spine surgeon, right? If we are able to establish what role perioperative rehabilitation has in terms of When should we start it? What should we do? How long should we do it? How intense should we do it, etc.? That spine surgeon has a much more objectively quantified framework that they can use in prescribing rehabilitation. And that allows them to prepare the patient for what that's going to look like better. So it improves their communication with the patient, and it also improves what their expectations can be of what kinds of outcome these patients might have. We know from a lot of other similar kinds of conditions, such as stroke, spinal cord injury, etc., that exercise can be a really pivotal, really key therapy for enhancing recovery. And in particular, well-designed and well-monitored high-intensity exercise can be really beneficial as well. The rehabilitation guidelines for spinal cord injury that came out in the last year or two are now actively recommending high-intensity locomotor training in individuals with incomplete spinal cord injury. There's evidence that high-intensity locomotor training especially, but generally speaking, all locomotor training can be beneficial for neuropathic pain, can be beneficial for improving walking recovery, and several of the other issues that individuals with cervical myelopathy might have. So I think we need to have some well-designed studies revolving around that.
So Tim has a really fascinating perspective on DCM. I mean, on the one hand, he's lived through it, he's undergone surgery, but on the other side, he's actively involved in the clinical research element in sort of rehabilitation therapies, exactly what this question is about. And I think one of the things that's quite interesting hearing from him is how he was struck by the fact that, all these other conditions, stroke, traumatic spinal cord injury, brain injury, rehabilitation is a gold standard part of care. And yet in DCM, there's absolutely no evidence behind it at this stage. And really its provision day to day is lacking.
Yeah, I was really surprised by this because it's such a big topic in the traumatic spinal cord injury field, and becoming more so because without any other form of therapy, it's all we have. And there's a huge amount of research in this area, stretching back years, where they're sort of aiming to determine when do you apply it, how do you apply it, how long for, what do you apply, etc., lots of questions. And I think perhaps like Tim, I sort of assumed that this information was being passed from one field to another. So I was really surprised by this.
And there must be parallels to build upon there, surely. But I think one of the interesting differences for DCM, and perhaps opportunities, which again, Tim touches on, is that surgery in DCM is a semi-elective undertaking. It's not like traumatic spinal cord injury where then there's a sudden devastating change and everything is an emergency operation. With this, everything's a bit planned. So there is that opportunity to start to intervene before surgery. That concept of prehabilitation exists, which is a part of many other diseases. And I think that could be a real opportunity in DCM.
Yes, absolutely. And it's a key point that Tim makes, isn't it? That with DCM, you really have this chance to put in some work beforehand, which will hopefully aid your recovery post-surgery. Whereas in the traumatic field, of course, it's just coming out of the blue. So everything you're looking at then is post-injury, post-surgery.
And these are questions you put to our next guests, Michelle.
Yes, two guests, in fact. First, we hear from Julio Furlan, who's a neurologist and assistant professor of neurorehabilitation at the University of Toronto. And then we hear from Armin Curt, who's also a neurologist and a professor of neurorehabilitation at Balgrist University Hospital in Switzerland. I started by asking Julio why there has been so little focus on rehabilitation in DCM, despite the evidence and experience from the traumatic spinal cord injury field.
There is a growing evidence to support the notion that timely rehabilitation using the optimal time, volume, and intensity of therapy can maximize recovery. There is quite a variation in terms of access and even in terms of the modality that it is applied and the intensity and the timing and the volume of the therapy. So quite a lot of variation that you need to account for when you're looking at the outcomes.
It's difficult to draw conclusions, I can imagine, when there's so much variability.
Yeah, that's really a major issue. And I think as we see in neurorehabilitation of individuals with traumatic spinal cord injury, that even though there is much better evidence in terms of the effectiveness of the neurorehabilitation, it remains a main point in terms of comparison of the studies and the effectiveness of the therapies because of all this variation that we see in the clinical practice.
Absolutely. So why do you think DCM treatment has not been a focus for rehabilitation?
Yeah, that's a really important question, and I don't think we actually quite understand yet what is the reason. It remains many times a delayed diagnosis because there was misdiagnosis initially. Sometimes it's based on the fact that our colleagues are not maybe well trained in terms of diagnosing or recognizing degenerative cervical myelopathy at the beginning of the symptomatology. There is also the problem of access of patients to specialized centers where there is a healthcare professional with experience and expertise in spinal cord disease, and there is also the problem of access even to patients to healthcare, which is quite variable in the different jurisdictions in the world. Just in my practice, where I suspect there is a cervical spine disease, including degenerative cervical myelopathy, my first advice is always doing a proper physical therapy, but really be concerned about some practices that I see sometimes is when there are colleagues, they try to do more extreme maneuvers, cracking the neck and realigning the spine, which I advise patients to not pursue this kind of therapy because one side is getting the benefit of the therapy, but the other side is do not get any harm from the therapy.
Would you be able to explain to us why there's a distinction between non-operative treatment and then rehabilitation?
So rehabilitation is part of a non-operative treatment, but in fact, it is an active therapy.
Okay, and then would you be expecting someone with non-operative treatment to eventually end up having surgery, or can you completely circumvent that?
That's an excellent question, and I'm not sure if you actually have the right answer. Right now, we see many patients that they are left for a few years with the diagnosis, and they are doing very well until they start progressing with neurological deterioration. But I also have seen patients with many years, even 10 years, with significant imaging corresponding to what is the diagnosis of degenerative cervical myelopathy, mild symptoms, and they persistently maintain the same symptoms. So we quite do not understand which subgroup would be required to have a earlier surgical treatment instead of having a no-operative treatment with rehabilitation only.
And on a practical level, just because it's very interesting, what would be the difference between an example of a non-operative treatment versus sort of rehabilitation post-surgery? What are the differences in terms of the exercises or movements people would be doing?
In terms of no-operative treatment, it usually can be active or passive therapy, but it's more in terms of exercise for the patient to maintain range of motion and the strengthening. But when there is a rehabilitation plan after the surgery, usually it is tailored with a realistic patient-driven set of goals where the patient tells exactly what they want to improve, and that should be within a set of goals that are specific, measurable, achievable, relevant, and time limited in terms of achievement for improvement of the function, but also quality of life of individuals.
And then the next question is, what is prehabilitation?
Well, pre-rehabilitation is a concept that includes the physical exercise and therapy and the lifestyle preparation prior to a surgical intervention. Stretching, light jogging, stationary biking as part of the warm-up can have a component that's more cardiovascular, which would include jogging, walking, in some cases resistance training using resistance bands and so on. There is also some programs that include flexibility training, including stretching, weightlifting, but also techniques of yoga. And then finally, there is the functional tasks as they do on a daily basis, like climbing stairs, going down the stairs, and sitting and standing. So it's a preparation for the surgery that they get the most of the outcomes when they have the surgery, and they are prepared to also transition to a post-surgical rehabilitation.
So I'm imagining that, this is very relevant to people facing surgery for DCM then, to get them ready for that and like you say, to give them the best chance of a good outcome afterwards. And how long would a program of prehabilitation sort of last?
I think that's another excellent question that we don't have the actual support from the medical and scientific literature to say. I would say probably at least 3 months of pre-rehabilitation. And again, that depends upon also the available resources, including financial support or even time or even personal support. Some of them, they depend upon family caregivers. So I would say at least 3 months would be a reasonable time.
I was wondering, what's compliance like? Do most people, once this program has been put in place for them, do they, turn up to sessions and do it? Or is that an issue that you have sort of motivation to do these exercises?
Well, that is more dependent upon each individual. But if they are committed to pursue surgical treatment, they are usually motivated to get better, which brings a subgroup of patients that are interested to do their best before surgery.
From your experience in this field, what would be your personal recommendations for answering priority 6?
I would say we still need to increase the awareness of degenerative circumyelopathy among the general public, but also among colleagues in the healthcare system, including healthcare professionals. And I think you need also to pursue further scientific work that can, again, demonstrate what is the most helpful and cost effective for this population. It is for certain the most common non-traumatic spinal cord disease in the world. So we need to put together our heads and understand better what works and what doesn't work, but also be wise in terms of how we're going to expand our scarce resources in the therapies for these individuals that are really necessary. The earlier is the diagnosis and the earlier is the intervention, the best is the outcomes that we see in rehabilitation. So increasing awareness would produce a much better outcome in terms of their own relief of their symptoms, but also improve of their quality of life.
Yeah, and I know that there's a huge amount of research in this field in other neurological disorders, such as traumatic injuries to the CNS, so strokes and traumatic brain injuries and spinal injuries. And I'm wondering how much crosstalk there is between the disciplines.
There is a crosstalk among the healthcare professionals, but again, we don't have much in terms of very specific analysis of the outcomes and data from non-traumatic spinal cord injuries. We know much better the therapies that work, the therapies that do not work, and their value in terms of optimizing outcomes after traumatic spinal cord injury than compared to non-traumatic and spinal cord injury, in particular degenerative cervical myelopathy.
And leading on from this last point that Julio makes about the importance of proper analysis of research findings, I next spoke to Professor Armin Curt, who's a neurologist and the director of the Spinal Cord Injury Centre at Balgrist University Hospital in Switzerland. I asked him what his views were on promoting research into neurorehabilitation.
Neurorehabilitation is the logic next step after you do an acute intervention, either a medical one or a surgical one. So you need to find the right way to get the change of the nervous system, being the brain or the spinal cord, to gain the most benefit from this intervention. So you need to train, as healthy people also have to train. And after a specific condition, you even have to have a better training, a more targeted and more, let's say, well-adjusted training to the limits and impairments you have.
And I think also it's important when that training begins, and that varies a lot around the world and after different conditions, doesn't it?
There's definitely further research required to understand the sweet spot when to start this neurorehabilitation. Based on preclinical findings, we intend to say the earlier the better. But it has to be a natural consequence of the care intervention and then the neurorehabilitation. And this sweet spot really needs to be better defined and then being applied. And as soon as we have good data to showcase that we have better understood this sweet spot, I think the international community interested in neurorehabilitation will just take it and go from there.
In particular with DCM, which is something different to traumatic spinal cord injury, there could be a benefit of rehab and rehab training prior to surgery, I imagine.
First of all, it's a chronic disorder which is slowly progressing, but sometimes has some steep ramps where it shows itself to be more prominent to the patient and also to the physicians. And the impairment, the unconscious impairment starts already quite early, and the patient is compensating for the deficits he does not know about. So a kind of a neurorehabilitation or conditioning the patient before surgery may be a useful way to actually then improve the outcomes of surgery. This perioperative rehabilitation actually entails that you have a better understanding where the impairment starts, and showing and being able to reveal that there is already some kind of impairment which is slowly progressing, and you can confirm that the course will be a bad course. You do not need to wait for deficits, so you should be proactive. And understanding this proactive level is also something very important to the DCM community, because the patients would have some certainty.
Yeah, I agree. And from speaking to members of the DCM community, I think this information just isn't out there. It seems to be really variable depending on where they're based and the expert that they're seeing. So I think a sort of better understanding and better communication of that would really help them, actually.
So we learned in the stroke field that when patients sense a sensory deficit or a transient weakness, that they should go and have a look if that may be associated with stroke. So people became more aware of this, and actually the patients coming early is actually increasing. And something similar is yet missing to advise patients potentially suffering from DCM. So they have no clue what to look for. And if you help them to better explain them early signs and symptoms, then they may be actually able to timely go and see the doctor.
What exactly are your recommendations for approaching priority 6 and how it should be answered?
So it should start with a very comprehensive assessment, understanding the deficits. And rehabilitation medicine is very good in understanding and appreciation deficits. And then you have actually the intervention, and afterwards you need to again then build on what you have been doing to improve then rehabilitation. So in my understanding, this perioperative rehabilitation is just part of this package, how to best treat patients with DCM. It's not a single event. There are many consecutive aspects that need to be covered.
So listening to these perspectives, I think both Armin and Julio clearly convey that there must be a role for rehabilitation in DCM care. We just need to better define this.
Yes, and they both highlight the importance of timing. So Armin refers to what he calls the sweet spot for this. And he talks about the fact that, of course, rehab is the next logical step after an acute intervention to make sure that you make the most benefit of that intervention.
And that's also interesting because I think it really references how interconnected these research priorities are. If we want to be able to better define a role for rehabilitation, we need the assessment tools to be able to measure that response. And of course, if we're going to be able to offer rehabilitation earlier, then we need to diagnose the condition sooner also.
Yes, it's all very connected. And I think in terms of sweet spot, what he's actually alluding to is the fact that it's been shown that sometimes when you apply 2 treatments at the same time, then the outcome of that can be worse than when either treatment is applied separately. So they sort of cancel each other out in a way. And there are published findings of this. It's certainly the case preclinically. And these findings have been used to inform clinical trials, of course. So for a specific example, there's an ongoing regenerative medicine trial for spinal cord injury for a therapy, an antibody therapy called No-Go-A. And in this trial, the treatment, the No-Go-A treatment, is given first, and then the rehabilitation starts after that treatment has been given. And this was identified as advantageous using a series of preclinical experiments leading up to the clinical trial. And the simple interpretation in this case is that what you're doing is allowing the CNS to be plastic and then pruning down those new connections with the use of rehab.
How interesting. Quite a different dimension. But I guess, of course, it again touches on the importance of having that research relationship both preclinically and clinically, of course, which we touched on in the previous episode. But I think on a much higher level view for me, this priority, something that's so exciting about it as a sort of clinically orientated researcher, is almost how ready it is to go. We have experience of rehabilitation from parallel diseases. We have techniques, we have infrastructure from parallel diseases. It's all there. It just needs some thought and attention.
Which is why, of course, it's one of the research priorities.
So thanks very much to Tim Boerger, Julio Furlan and Armin Curt for joining us. The podcast was researched by Elizabeth Roberts and produced by Carl Homer from Cambridge TV.
There's lots of information to be found at www.aospine.org/recode. Thank you for listening. We'll be back next week with the next item, number 7 in our top 10 myelopathy research priorities from AO Spine, novel therapies. Don't miss it.
And to make sure you don't, why not subscribe via your favourite podcast app? Until then, goodbye.